Righto then. Good afternoon, ladies and gentlemen. Welcome to Grand Rounds in the fancy new Wolfson Lecture Theatre rather than the Gannicky. I'm sorry that I advertised the wrong place. My name's Tom Fowden. I'm a chair today. I'm enjoying Grand Round from the luxury of annual leave, but I forgot to ask someone to cover for me, so here I am. And what a pleasure it is to be here on my annual leave. So, I shall get through the parish notice as quickly as possible because we've got a packed programme with 4 speakers talking about an E-Coli outbreak and the changing faeces of microbiology. I do love a good pun. Right, the University of Dundee has been ranked 1st in Scotland, 3rd in the UK and 14th globally for overall average student satisfaction in this year's International Student Barometer. More than 180 institutions in dozens of countries were included in the survey, including 42 of the UK, 8 here in Scotland. This is the latest in a long line of accolades for the university, which was recently named the Times and Sunday Times Good University Best University for the 2nd year in a row and recorded its highest ever scores in the most recent National Student Survey. So well done to us. Researchers in the University of Dundee have found that skin cancers in mice can closely mirror those found in humans, offering a model that could be used to help develop new drugs and find new ways of preventing the disease. Until now, there's been no effective preclinical model which could be used to test and develop new treatments. Now the Dundee team say they found that mice could offer new insights for non-melanomatous skin cancer. The team is led by Albina Dinkova-Kostova, Professor of Clinical Biology at the School of Medicine. The next step will be to use the model to study potential pharmacological agents. A big step forwards. The University of Dundee has launched a £25,000 competition to support new business ideas among students, staff and recent alumni. Applications for Venture 2017 are now open and must be submitted before midnight on Sunday the 5th of February. Details of how to enter are on the screen. The Saturday evening lecture series starts up again this month, kicking off with a talk from the University of Dundee graduate and Chief Executive of Archie, David Cunningham. David will be covering the untold story of the O'Wully Bucket Trail. Not to be missed, it says here. Early stage trainees can apply for a travel award of up to £300 to present at national and international scientific meetings. Applications close on the 1st of February, so if you're planning to present somewhere this year, don't leave it too late. Get your application in as soon as possible. If you're a student and you've ever fancied working somewhere more rural than Dundee, the integrated longitudinal clerkship could be for you. You can undertake a 10-month-long placement based in Dumfries and Galloway or the Highlands. And if you can make it on your way back again, we might even see you and you'd be a doctor back in here again. There's some information on the slide here, but you can find more details from Dr. Penny Lockwood, who's p.lockwood at dundee.ac.uk, she says. There's 2 more staff development opportunities this month if you want to learn more about how to teach on Core Skills 5 assessment and then a learning cafe. And there is lunch available on the 25th of January. Now it's over to the team who are going to present. I'm not sure which order, but Jackie's getting up first, so that's probably who's going to speak first. They're going to talk about an E. coli outbreak and the changing faeces of microbiology, if I can find the right presentation. This one. There you go. There will be questions at the end as normal with the roving mic. Thanks very much.
Thanks, Tom. I'm just going to take a few minutes to set the scene for my colleagues here, just to really bring up a big issue which happened recently that many of you may be aware of. And it's really to ground the fact that this hospital works inside a whole area, a world out there with people who are living and playing and working. And what happens out there has an impact on the hospital, and what you do in here has an impact out there. And we want to show you how that is very, very important. So it's going to base it on a story, once upon a time story, in a place not so far from here in Carnoustie. In September of this year, there was a playgroup up that had an outbreak of E. coli infection. Now, E. coli is a pretty nasty wee bug, and when it comes to playgroups in nurseries, it spreads very, very, very quickly. The most of the cases you see of E. coli infection occur in children under 5. Okay, so when you have a case in a nursery playgroup, you can guarantee that it will probably spread if they are not absolutely rigorous about the hygiene. And you may see an outbreak up to 30% of the children in the playgroup affected at any time. So it's a really big issue for us. So because it spreads so rapidly, we have to get in there very, very quickly, and we do run a 24/7 service, 365 days of the year, to identify particularly E. coli, to identify the cases and find out who their contacts are. And our main aim is to sort of stop that spreading any further, to sort of corral a lot of the disease. The reason why that's really important is because, first and foremost, any of you work with children or do any sort of GI stuff, that E. coli is incredibly difficult to diagnose. And because it's difficult to diagnose, people will be spreading it before they know they've got it. And we have to stop it, because the outcome of not stopping it can be quite significant. So we have a very precautionary approach, which means we have to intervene before we even know they've got E. coli, often in cases only on symptoms. And the consequence of that we'll describe later in terms of the workload. So really, the consequences are, for many people, quite severe illness. Hemolytic uremic syndrome can affect 9 to 11% of the kids, and that's kind of almost a worst case, and the worst case is fatality, which can affect 1 to 2% of cases. Those in the over 65 years tend to be affected more in terms of fatality, but for the kids it's quite significant. I was involved in an outbreak in Fife in 2009, and out of the 8 cases affected, 6 of them needed renal dialysis because they ended up with HUS. And they had HUS before we even knew they had diarrhoea. So it was a really, really big issue there. So the other problem is that many people have a mild illness, so that they may be dismissed as having just had a short period of diarrhoea, and people don't think it's connected, but it is very important to check everything out if they're connected with a positive case. And then we have asymptomatic carriers. They're less likely to spread it, because they haven't got all that flowing diarrhoea running around, but at the same time they can spread it if they're not using proper hand hygiene, etc. And the people changing nappies can spread it if they're not careful. So how big a problem is it? Well, this was an estimate, 130 cases, or an early figure, 130 cases, unconfirmed. It's gone up to 180 for 2015, but usually in Scotland you see over 200 cases across Scotland. In terms of predicting how what those cases are presented with, 70% will have bloody diarrhoea, but it's really important to know that bloody diarrhoea doesn't mean a profuse blood in the stool. It's not Ebola-style bleeding. It can be small, it can be a trickle, it can be just a minor little smear or marking, so it's incredibly difficult to pick up and often is dismissed. Because many people also, 25% have diarrhoea without that, and the others are asymptomatic. So how do we know that these people have E. coli? It was because we pick them up as contacts. We pick them up if anybody in connection with an E. coli case has symptoms, we get them tested, and that's how we get these figures. So in terms of the problem, is it a big problem, it's a growing problem? It varies so much year on year. You might quickly scan down and see the big number there under Orkney of 23.2, but that should be dismissed because it's a very small population, so it's going to be sort of a couple of cases is going to make a big impact. In terms of Tayside, which is the figure down near the third from the bottom, it varies year on year, but at the end of the day, there's quite a significant amount that we do have in Tayside, 1.96.15.6 per 100,000. So it's quite variable, but you can see it still tends to be above the Scottish rate, which is the lower figure in Scotland, 4.93.1 in those years. The reason for that, you tend to see it in the places where there's lots of country and cows. That's in Grampian, Dumfries and Galloway, and Tayside were the highest places. So what about Tayside? Now, quick cases of E. coli. These are not all diagnosed cases. These are cases that we have to start dealing with, and that's where we want to take this talk to. It's the amount of work that's required in terms of dealing with them. In 2014, we had 36 reports that somebody might have a confirmed, a possible, or a probable case of E. coli, and every one of them has to be investigated properly. You have to investigate them both clinically and in terms of their contacts. And what we want to do is now explain the level of detail. 2016, you can see we had 257, and a lot of that is linked to the outbreak. Not all the cases, but a lot of that is linked to the outbreak. So one single outbreak can really make the numbers go very big. So that's really just to set the scene for you. And now we're going to show you what happened when those kids ended up going into a paediatric unit.
So hi, for those of you who don't know me, I'm Linda Clare-Hugh. I'm one of the paediatricians. I happened to be around the week this happened. I fortunately wasn't the person on call, which meant somebody else was carrying the majority of this workload. And all I'm really going to describe to you is actually the chaos that this creates in an inpatient unit. Within paediatrics, we deal with infection. That's what we do. That's about 80% of what we do. So actually we're quite good at infection, and actually, to be honest, we snigger a little bit when we start seeing the emails coming round about we've got flu in ward such and such and diarrhoea in ward such and such, because that's what we have all the time within paediatrics. We see about 7,500 acute referrals a year. Most of them are infectious, but about 10% of them will have gastroenteritis. So clearly we are not flagging those 10% to public health, saying they've got E. coli. So there's a few things that we think about. Most of our kids who are sent in with gastroenteritis are sent in with dehydration and actually respond really well to ambulatory rehydration and discharge back home within a few hours. But there's a small number of children we'll not do that for. And the ones we're really thinking about are the ones with red flags. So is there a travel history that we need to know about? Now, not many children travel to really exotic places, but it does happen sometimes from Tayside. But more actually, do we know there's something else going on somewhere else within Tayside? And obviously as a paediatric unit, we're covering the whole of Tayside. We're the admitting unit for the whole of Tayside. So we're going to get stuff in Perth and Angus and Dundee. So we are almost automatically looking for contact tracing the time somebody comes in. And when somebody's referred to us, prior to them being admitted, we've already taken a note of the school or the nursery they attend prior to them arriving. So we're already starting to look for contact tracing before kids come in. We're not going to ambulatory rehydrate anybody who's got bloody diarrhoea. We are going to take that seriously. Now, there's an infectious element to that and a non-infectious element. Presuming we're just thinking about the infectious ones just now, we are going to treat them seriously because it's much more likely they have something bacterial. And for us, it may well be that that's E. coli, and that can have very significant onward consequences for the kids. So thinking just about the ones that have E. coli, they'll come to us in two ways. They'll come in as somebody with bloody diarrhoea or abdominal pain and fever with diarrhoea, who we then can subsequently go on and look at, or they'll present with hemolytic uremic syndrome. And to be honest, the majority of them do present as hemolytic uremic syndrome. That's how we find out we have got something going on with E. coli in Tayside. Kids with HUS are sick. Really, really sick. So for us, we've got a medical emergency is how this comes in. So for us, the medical emergency bit of this will always take priority over the public health element of it. We've normally got a resuscitation episode going on with somebody who comes in with HUS. They're sick, they're anemic, they're thrombocytopenic, they might be bleeding, they're hypertensive crisis. They are sick, sick children. So that's always going to take the priority for us. But in the background, we know that actually there's an infectious element to this and there's a contact tracing bit to go on. The outcome for HUS is not great. It happens in about, as Jackie said, about 5% of kids who are sporadic, but about 20% of kids who are in an epidemic of E. coli, VTEC producing E. coli. It also happens in other infections. So actually a lot of our HUSs have got other infections like adenovirus or pneumococcus, which accounts for 5 to 10% of them, or other infectious diarrheas. The outcome's bad. About 30% of them will have ongoing residual renal disease, and it's got a 5 to 10% mortality. Okay, so that's the bad end of the spectrum, and that's really what we are trying to prevent anyone getting to. So if we are seeing somebody who's sick with diarrhoea, we're trying to stop them getting to that end of the pathway. The difficulty is, as Jackie said, often the kids who've had E. coli have been asymptomatic at the start, or had mild diarrhoea, or a bit of tummy pain, but actually not very much at the start, and the HUS is delayed. So the HUS doesn't happen at the time they've got a diarrheal episode. So the contact tracing is often deferred by about 10 days. We've got a gap of about 10 days at that stage. So what we do when we get somebody, whether they're coming in with in sort of bloody diarrhoea element of it, or the HUS bit, is we do the medical management bit, which is the stuff that you're all very familiar with. We've also got to do the notifying of public health. Now we have to do this quite a bit in paediatrics for a variety of different things. So we notify public health, it's a notifiable disease, as are many other things. And then there's a time gap. So essentially we know we've made that phone call, and then what we're doing is waiting for the results of that phone call. Now generally we're making that phone call quite early in a day, and we know by tea time there will have been an explosive result to that phone call, because that's essentially when Jackie's team are then busy ferreting away doing contact tracing. And that's the same for any of the other outbreaks that we see of anything. It's a bit like waiting for a major incident. You know, you get the phone call from the police or the fire or whatever, and then you're standing by and there's a sort of pause of not quite knowing what's going to happen. So once we've made that phone call, we know we've got a gap and something's going to happen. In that gap, we've obviously got the medical management of the child that's come in. And what I'm saying by symptomatic management is it's obviously different for somebody who's got gastroenteritis from somebody who's got HUS. So we're doing that bit. There's infection control measures put in place anyway, automatically, if you come into a unit with diarrhoea. We might have to think about analgesia. We may have to think about IV fluids to manage dehydration. And previously that's what we did. So if you had diarrhoea and you weren't dry, we didn't bother IV rehydrating you. We don't give antibiotics for anyone who's got bacterial gastroenteritis, particularly with E. coli, is it might actually increase the risk of producing a toxin that then causes the HUS, so it increases your incidence of HUS. However, recently, and when I say recently, I'm talking halfway through this outbreak, the national guidance for what to do changed. And that's based on the fact that there's some evidence coming out now that if you have got bloody diarrhoea, so you've got endothelial damage from the toxin at that stage, if you volume load somebody at that stage, then you can prevent them getting the HUS. And the odds ratio is about 1.6. Now, given the disastrous outcome from some of these kids with HUS, there's a significant benefit to us thinking about that. So it seems relatively easy. We get them in at the point that we're getting them in with bloody diarrhoea, and we start volume loading them for the first 96 hours. Except it's a little bit more complex than that, because we've made that phone call to public health, so we've not just got that one patient. So that waiting in the gap is actually waiting for Jackie to then phone me and say, by the way, this nursery is this size, and there's this number of children at this nursery, and they're all contacts, and the staff, and all the rest of it. So we've kind of got that, okay, this is a bit bigger than we thought it was, it's not just the one case. At that stage, Jackie's team will refer to us anyone who is a proven case or anyone who's a symptomatic contact. And they have to come in for medical assessment. And if they're VTEC positive, they should be volume loaded for that 96 hours. And they require blood testing every 48 hours until day 14 because the HUS is delayed. So you've got that diarrheal phase and then the HUS. You've got a 2-week follow-up period for these kids. And that sounds great. That complex pathway on the left, which I'm not asking you to read, tells you actually it's maybe not quite as simple as that. Because actually what we have is a delay. So we have that child coming in, we get a stool sample, it takes 48 hours for us to send that to the lab to culture it and see what's growing in it and then be told it's E. coli. It might come back a bit faster than that, but generally it's going to be 24 to 48 hours. That tells us it's E. coli or not. It doesn't tell us whether it's a toxin producing E. coli or not, so it then has to go down to the reference lab to then be looked at to see if the toxin producing ones, which is the ones that then cause the problems with HUS. And that whole process takes 4 to 6 days. So actually, anyone who's a contact is having to come into our unit and be treated with that IV fluids for 96 hours. So the real question is, okay, we've got that one case that's come in, but what's the end consequence of that? How many more are we going to expect? We're a 41-bedded inpatient unit. We're a mixed unit of medical and surgical day case and inpatients. We have a mixture of infection patients, so that's our beds are probably divided about 2/3 for infection, about 30%, 35% for non-infectious barrier children, so our kids who require oncology treatments or any other immunosuppressants for other long-term diseases are managed in the same unit as our infection kids come into, so we've got a significant problem with cohorting. And actually, we could be expecting large numbers, so what do we do with the vulnerable kids in there to protect them? And we've also got all the other stuff that's infectious that's coming in. So we've got flu at the same time, we've got adenovirus at the same time, we've got every other virus you can think of at the same time in our unit. So we kind of need to have an idea about the size of it. There's a paper, Hugh Pennington's done a paper looking at actually how many children can you expect in an outbreak, and it varies between 2 and 40 in any outbreak, but actually we'll have 2 to 3 times as many contacts you're having to treat as well. And we've got other co-infections at the same time, which might be other E. coli, it might be adenovirus, it might be flu, it might be anything else. So the workload's huge. You've had that phone call. We don't really quite know what's coming. We like being nice to our patients in paediatrics. Okay, so we like being open and nice and friendly, and you come in and it's all very nice. And there's been a big competition recently to decorate our front doors, see which paediatric team could win a prize for the best front door to their ward recently. So that's all very nice. Actually, if you have infection, we're not that nice to you at all. Because what we do is we divert you through the building. You're not allowed to come in through the main front door because that means you're contaminating our clean end of the ward. You're diverted through the hospital to the infectious end, to the back door of the ward where you have to ring a bell and wait to be allowed in. We had to think of a system, when we were thinking about the number of kids that came through, we had to think of a system about guiding our patients through. So public health had to be able to say to them, just follow something. And because we're nice and we're sunny people, we said, follow the sunshines to the back door of Ward 29. I'm not sure that actually that was the right sign, but because of the press interest in a variety of things, we had to do it that way rather than being as quite avert as we are. Patients then come into a 6-bedded bay. Often these kids are relatively well. Okay, so if you're a well child, sitting in a bed on IV fluids is not that easy, because actually you want to be in the playroom, but you're not allowed in the playroom because you're infectious. Your parents are also in there and probably their siblings. Okay, small contained space, active busy children who are not actually that unwell at the time, have to stay within the red lines. There's not much space between the red lines and the bins and the soiled waste and all the rest of it in the sink from the infection control point of view. Mum and Dad are also there. They are by definition contacts, of what we don't quite know yet. They're adults. We have children's toilets in a children's ward. Okay, they're small. It's a bit like going back to primary school. Okay, they're not made for big bottoms. We have 2 sets of toilets, boys' toilets and girls' toilets. We have a clean end of the ward. So essentially, having something like E-Coli come into our ward totally and utterly disables half of our ward. So something like this, even if it's only 4 or 5 patients, disables the toileting facilities and the bathing facilities and everything else for half of our unit. It's the same for the parents' lounge. Okay, parents staying with a family are not allowed to be ordered meals through NHS Tayside if your parents staying there. We have a parents' lounge facility where you can go microwave things, except if you're infectious, you're not allowed in there, because then you would contaminate the rest of the patients and parents that are in the ward. We have a playroom you're allowed to go to, you're not allowed to go to that, so everything has to be brought to your bedside. It gets really tricky. And actually it's quite an explosive environment, because these families all know each other, they all come from the same place. Okay, so they're all at the same nursery, they're all at the same primary school, they all know each other, and they may or may not get on, but it becomes quite an explosive environment quite quickly. So we had cohorted our patients, not quite sure how many we've got coming in yet, so actually what we had to do is cohort our staff as well. So we have to allocate a team of staff to just manage the E-Coli outbreak, or whichever other infection outbreak it is. Because essentially we're going to spend the majority of a day on a telephone. That member of staff is going to have to be doing the contact tracing with public health and waiting for those phone calls coming in, and is also the person who's then managing the families and the information to them. There's a bit about cohorting of information. Okay, huge press interest in any form of infection outbreak. We sit in an end of the hospital which you can easily access from the car parks. If you're a child and an inpatient, you only come into one unit. So actually it's quite easy to identify who's coming in and out of our unit. If they start knowing each other, it's quite easy to start tracking people from nursery up here, which is what happens. And the press have huge interest in these things. Okay. For clarity, we didn't quarantine anybody. We don't quarantine in paediatrics. What we did do was eventually decanted from Ward 29, which is our inpatient unit, into our elective day surgical unit, which is a contained space, and gave us bed facilities and all the infection control ability to actually isolate everybody from everything else. So that's essentially what we did. So that became our poo zone during this epidemic. So we need to think about this. We're seeing 2 to 3 times as many children as we need to, essentially, because what we're doing is we're wanting to treat the ones who are at risk of getting HUS. But by default, we're having to treat everyone who's a contact, because they may have E. coli, we just don't know, and it's going to be 5 or 6 days till we do know. You've got to give them fluids for 5 days. They're in there, they're bouncing about, they're fighting with each other, and actually they're all waiting for the same result. So again, this explosive environment becomes hugely explosive when you get one result back and not everybody else's. Okay? And I want you to think about the onwards consequences of, actually, if we knew who was VTech positive, would that help us? And the answer is undoubtedly yes. Because actually all we would do is admit those that needed to come into hospital, which is about 1/3 of the kids that we actually saw, well, about 1/4 of the kids in this epidemic, of who we actually saw. There's clearly a risk if we're admitting people who are contacts, who are not infected. There's a risk to that because we're admitting them for IV fluids. Now, coming into hospital, I know we're safe and I know we're a great team and I know we're lovely. However, there is a bit of a risk about coming into us. And that risk for coming into an inpatient unit in paediatrics, you've got a sort of hospital-acquired risk rate of about 10%. So we're going to do stuff that we don't intend to do to patients. IV fluids is not particularly safe. It's actually not very nice if you're a child to get pinned down and get a cannula put in and get your bloods checked and all the rest of it. It's very invasive. If you're a young child, it's very scary. So we don't necessarily want to be doing things like that to them. Could we have managed it if we were just managing those who were confirmed cases within Ward 29? Absolutely. We could have managed the numbers. We wouldn't have had a decant. There's significant ongoing consequences to that. Not everyone's infected at the same time, so they present over a 2-week period. So actually we've got staggered admissions over a 2-week period and staggered follow-up for another 2 weeks. So the whole outbreak takes about a month to 6 weeks from start to finish. If we had that, we'd have been able to reduce all the cancelled work that we did have to do. And it reduced significantly hours of follow-up. So there's all these contacts who actually become non-contacts very quickly, who actually don't and then have to do all the effort of phoning and chasing up after that. Essentially, from a financial point of view, so if we're thinking about this, if we're looking at having VTech testing, that we have rapid access to results within Tayside, which Dave's going to chat about, what would that have done? Well, it would have prevented, had we gone for the full pathway from the start of this outbreak, it would have prevented 120 inpatient days over a 2-week period, 15 cancelled theatre days, lots of medical elective work cancelled at the same time, including patients, and actually that follow-up blood testing that I'm talking about for 2 weeks, until we get that test back, we've still got to carry on doing blood tests and things to kids which are invasive. And actually, as Tina's going to chat to you about, there's an awful lot more to it than just what is seen by NHS Tayside as the clinical impact of this. There's huge impact on the families as well.
I'm Tina McMichael. I'm the Advanced Nurse Specialist for Health Protection, and I lead the Health Protection nursing team. I'm going to talk a wee bit about the human costs that were involved with this outbreak and how a change to testing can actually impact positively on my patients out in the community. So when you're talking about human costs, I tried to do a wee bit of literature review around this. There's not actually a great deal in the literature about how exclusion orders and outbreaks then impact on our families and our communities. So what I'm going to present on is anecdotal information gained from our families about how this actually affected them, how the illness affected them, how the exclusion order actually impacted on their child's well-being. So, what we're talking about exclusion orders. Public Health Department work within the Public Health Act 2008, specifically Part 4 of that Act. And that means we can put exclusion orders on people who have got an infectious disease who present a danger to other people in the public. So this is the exclusion criteria we put into place for gastroenteritis illnesses. So if you think about our outbreak, each individual case needed a risk assessment round about that person, the family, and any of the social contacts that that child had been in contact with. So we have to look at the type of contact, the frequency of contact, and how that contact came about. When was it, the timing of it, is the contact ongoing? And based on that risk assessment for individuals, we then put exclusion orders on people. As I say, exclusion orders are a legal process. So then if families decide to go against our exclusion orders, we can actually look for prosecution for that. So as a legal outcome, we need to write to them, need to tell them, we need to write to them and follow that up and keep contact with the MD that's on an exclusion order. So for this particular outbreak, at the end of the day, we had over 1,000 days lost. Now those days lost are children going to nursery or school, or indeed adults going to work. Because if you're excluding a child, you're excluding that child from everything, and the adult then has to be at home to look after that child. For the children, as I say, it was 1,014 days excluded. If we introduce rapid testing locally, we can actually reduce that by 322 days. So that's got a big impact on their schooling, their education, their social development. Because from the families, we've identified that the lack of social interaction and the lack of educational experience within an outbreak does impact on their social development, their language skills, their emotional skills. And some of their families saying it actually then can impact long term on their academic ability. As Linda had highlighted, people can be in hospital and being looked after for days and weeks. Our exclusions, the biggest length of our exclusions we had on children can be up to 44 days, 6 weeks. And that's what happened in this outbreak. We had some families and it was like 44 days, so that's over a month missing of interaction with their peers, playing with their friends. So we need to consider that when we're looking at the E-Coli. When we're looking at exclusions, we're not just talking about schools and nurseries. We are talking about you're not allowed to go to soft play, you're not allowed to go swimming, you're not allowed to go to work if you're working with a risk category, if you're in category C and D, if you yourself are a contact of your child and you're going into a healthcare environment, we would consider that as a risk until we definitely know that you yourself are negative. We can't start testing you to make sure you're negative until we know your child is negative. So say that's taken 6 weeks for a child, and technically then we start testing you. We don't do it all that way all the time, but the guidance is quite clear. If you've got direct contact with your child, you can be picking up E-Coli right up to the time that they're negative. So how does that work in life? We risk assess it, we try and make sure that everybody is risk assessed and followed up appropriately. As I say, these areas, the schools, the nurseries, childminders, toddlers and playgroup, workplaces, if we've put exclusion orders onto you and your family, we also need to be following up all your contacts to see where your child has been or where you work. And it's up to me and my team to make contact with these places, to make sure they're kept informed, and your child is not allowed to go back to any of these places unless we say so. And those places don't accept children back unless they've had word from us. As I say, the testing, Linda linked into the testing. When we put exclusion order on a child and on a family, it's based on that child being positive and everybody else round about that child being a contact. So once a child's positive and you're a contact, once they're negative, we start testing you. As I said, it can be quite a long process, and we're expecting stool samples to come in every 24 hours. So how does a family deal with that? That can be quite difficult, getting a stool sample off a child. I know quite a few adults don't like to do it for themselves, never mind a child. So it can be quite a lengthy process. I've put media impact in here, and I just want to quickly touch on it. There's an awful lot I could say about the media when we get involved with outbreaks. They can either be really nice to us or they can be quite difficult. This particular outbreak, they made it quite difficult. They turned up at the school, they turned up at the nursery, they turned up at the hospital site, and they actually followed parents from the school home, causing quite sort of fear and distress in the community. The community were quite anxious about the media interest it had in the stories. Then we've got the sort of social media, and social media is great. The media actually found out about the outbreak through social media because parents from the areas had been chatting, and it was picked up and sent to the local newspapers. But unfortunately, somebody somewhere down the line started talking about specific names. As at NHS, we're always very clear that we need to try and keep everything as confidential as possible, so not to impact negatively on that patient and on that patient's family. Unfortunately, when names getting bandied about on social media, then the media actually picks up on it. We can't confirm or deny to the media, and we do not interact with them. If they've got an accurate representation, we don't address that. We just stick to our reactive statements and try and move on. But you can imagine if there's individual names being mentioned, that stigmatises that person in that family. So then try to return that person, child, to school or nursery can be really quite difficult because it's all the finger wagging and pointing. Name blaming. People were getting blamed for this. Nobody asked to have E-Coli in their area. Nobody asked to pick up E-Coli, but we do have a blame culture around about it. Moving on to the nitty-gritty though, because I was talking about human costs, but I want to talk about the actual impact of loss of earnings this has on families. Now, we know quite a number of our families are either unemployed or actually earning less than the minimum wage of £7.20 an hour, but we don't know that until they actually tell us. So if you think that's fine, if you're on a minimum wage though, or a 0-hour contract, or unemployed, you don't get paid and it's not protected if you have to go off sick to care for your child. And technically you're not sick because you're caring for your child. So that is a negotiation with managers and organisations. If you're on a bigger wage and you're working for a bigger organisation, your wage is kind of protected if you have to go off sick. You do get sick pay and things, or like so if you're working with the NHS, we get paid for 6 months anyway, so it's not really going to impact us, is it? Or somebody that's unemployed and they've got a child that's off ill and they have to stay off to look after that child. Does that impact on them? You might think, well, financially, no, it doesn't. It's fine. But we actually know within outbreak scenarios, and if a child is ill, it can actually push families into poverty when this happens. And I'll explain why. So if you've got a child in 9 miles, I won't go through this bit by bit, but you can think you're working in 9 miles yourself. You know how much it costs to travel and park here. Then if you've got a child, we've just put up the estimates for the amount of times. Then if you've got a child that needs follow-up at the clinic every 48 hours, plus putting a stool sample in every 24 hours to a GP, how is that managed? Don't know. Then if you've even got a child going over to Glasgow, we've estimated the Glasgow for a 3-week stay is I say £1,200. That's not including the cost of maybe a hotel for extended members of the family, siblings going along as well, staying overnight. But you also have to think about when children are in hospital and a parent is staying with that child in hospital, the separation that happens between other siblings within that family. And we basically, some families say, well, siblings are not allowed to go and visit because they're infectious. So try to protect, we don't say that, but some of the parents have said to us, to try and protect you, oh, can I let them visit? You're like, they can visit, you just need to be careful. But you have to think about the breakdown in relationship and the stress that that can form for relationships. So moving on quickly, loss of childcare. For those of you who don't have children, you have to pay for it whether your child is there or not, which I think is a wee bit shocking, but not my decision. So if you take an average family that parents working, taking time off to care for a child, and for an average family will say they actually just needed an overnight stay, but they had the mean exclusion of 11 days. You're talking about £430 just for that, and that's not all the additional extras. So just one overnight stay plus 11 days exclusion. No follow-up at hospital needed, but £430. If you're on a minimal contract or a 0-hour contract, that's a lot of money. If you take a similar family with a child inpatient stay for 5 days, follow-up for 14 days, you're talking about £1,700 or thereabouts. And that's not including your extra childcare costs to your nursery or daycare placement. So it's quite a bit of money. If you're talking about somebody that's in nursery, like a guaranteed nursery, you can be talking about £1,000 in addition to this. So it's quite impactful when we have that situations. Public health compensation. As part of the Public Health Act, we can compensate people for loss of earnings. But that is solely loss of earnings. That is not about childcare costs. That's not about their travel over to hospital or any additional extras they might have had. These figures are not just for single families. This was for multiple families. So even if you divide the latest one is the 5,600, that still doesn't add up and still doesn't really adequately compensate families. That's all I've got to say about the financial cost to humans. But what I will say as well is the cost of the Public Health Department. We were basically working 3 weeks solid, long days and weekends, pulling in other consultants and specialist registrars to help doing his work. I pulled in another nurse to help my team. We had extra admin team doing this for a good 4 or 5 weeks, but specifically for the first 3 weeks, we were working full-time, full trot to try and get this under control. As I said, the main thing for us is making sure all the families are supported through it. And that does mean supporting them through the media interest, the financial impact, the testing, try to explain the testing results as to why it's difficult for us. We can't just send everybody back when the child is negative. We've got to make sure everybody else is fitting well. And now I shall hand over to Dave.
Hi, I'm Dave Euro, Clinical Lead for Medical Micro, and this is where we come in. So from the previous talks, the message to microbiology is fairly clear. The message is that local PCR rapid testing for E-Coli would have improved the situation both for patients, families and professionals. So, yep, we could set up E-Coli PCR testing in 9 wells. It will cost a certain amount. We could do that. Current climate, it's unlikely, but we could do that. But for a similar sort of cost of setting up just a PCR for E-Coli, we could do so much more, and that's what I want to talk about now. Take you on a tour of medical microbiology. You send a fecal sample into us for testing. It goes something like this. If you're looking for bacteriology, everything gets cultured, and that takes about 24, 48 hours. 48 hours certainly for a negative. And a proportion of these, so that's by culturing, that's spreading out on a plate like classical microbiology, as you can imagine. We look for Clostridium difficile in some. That's an immunoassay, so it's a separate platform, separate test. We also look for parasites, Cryptosporidium and everything, and microscopy, again, classical test, but you need to know what you're doing. This is a fairly skilled activity, and it's a different platform. If you've got travel associated with it or anything special, we might look for other more exotic parasites as well. Okay, that's bacteriology. If you also want to do virology, you send in a separate sample for virology. And if you're over 5 years of age, we do a PCR, a molecular test for norovirus. If you're under 5 years of age, we'll do the norovirus, but we'll also do a separate test which looks for antigen of adenovirus and rotavirus. So you've got about 1, 2, 3, 4, 5 different techniques, all going different ways for different people with different skills on different benches. Okay? Fairly complex. Takes 48 hours, 24 hours sometimes, and there's an argument just for reducing complexity. So we look at other platforms, and a molecular platform can reduce the complexity considerably, if I show you. If we induced a PCR, a molecular test looking for DNA or RNA of the pathogens, it would go something like this. Fecal sample comes in, we put it on a molecular platform. Okay, that's it. 24 hours, you get the result. For everything, positive and negative. Simplifies the whole process enormously, which saves on time, effort, and so on. I'll come on to that. We think this is so smart, we call it poetry in motions. So, advantages of molecular testing. Clearly, I'm going to say there's lots of advantages. But if you think about it, just simply, you send a single sample to medical micro, not one to virology, one to bacteriology, not one for C. diff and one for noro, one for culture. All gets tested for everything, simplified. 24-hour results, both positive and negative. Very important, negative result. Most of the samples are negative, and the negatives take the longest because you have to wait until you're sure it's negative. You give it 48 hours. Okay? So they take longer. The negative could possibly be far more important than a positive result. We reduce repeat samples. People waiting for a result to come through, and they go, oh, have we got a result? Oh, we'll just send another sample, just send another sample. So you get repeat samples for no real reason. From a laboratory point of view, so that's from your point of view, sending in samples. From a laboratory point of view, it's less hands-on time. We're not lots of different skills, lots of different people. Less skilled staff. Doing the same thing every day, day in, day out, you can use people who are not so highly skilled. And it also lends itself to everyday testing, so you could have this testing more often. I'm not saying we can do, because no one's going to pay for 7-day-week testing at the moment, but it does lend itself. Disadvantages, be unfair if I didn't show some disadvantages as well. It detects only what you're looking for. If you put a lump of poo on a plate and plate it out, what grows, grows. Okay? With PCR, with molecular tests, you have to decide what pathogens you want to look for in the first place. So you only get what you're looking for. Clearly, we look for everything we expect. You also detect what you weren't asking for. So if you send a sample in for norovirus, you'll also get C. diff and you'll get Campylobacter and other things. Is that a problem? Well, it's something you can get over, I think. You can pick up dead organisms. Now, this is a good sign and a bad sign. You can pick up things that are dead in there. If you've given antibiotics to someone, you can still detect them by PCR when you wouldn't necessarily culture them. So that's good. The bad side is that dead organisms stick around for a lot longer than possibly the symptoms do. So you can detect things that possibly cleared, and there's also things like carriage, that people will carry organisms that are not causing them problems. But we're only really looking for pathogens, so hopefully you can work your way around that. So the upshot of that, you may get a few false positives, things that people have cleared or things that are not associated with their current clinical symptoms. But what you will also get is mixed infections. We found this, anybody who can remember when we introduced respiratory PCR, you you only sent something off looking for a flu, but you got RSV, human metapneumovirus, coronavirus, and loads of other things, human respiratory thing. You got things that you weren't expecting, but you also got things you never even heard of up until then. And possibly like this, GPs will get results for organisms they weren't expecting. But you learned to deal with it and associate what you found with what was wrong with the person, and you associate those two, and you learn to deal with it. It's a different way of looking. But the main disadvantage, as you can expect, is cost. It is more expensive on the surface. However, we believe there are savings both in the patient and the whole healthcare system that will outweigh extra laboratory costs. By far. That's our belief. Sorry, my belief. So, being scientific, we did a study. And to look at what advantages there would be at a technical level. So we talked to a load of companies and try and persuade them to do stuff for us. And we finally linked up with a company called Luminex. And after a lot of persuading, they supplied reagents, equipment, and training free of charge for our study. So this cost NHS Tayside nothing. We tested 200 known positives and about 600 consecutive samples that came through, poo samples that came through. And that only represents about 2 or 3 weeks of samples that come through. We do with a lot of poo, okay? You don't need to wear wellies, but it helps. Okay. And then we compare the results of the molecular method that Luminex supplied with our traditional methods. Now, clearly, if you've got 2 methods, you're going to have one result with one result with the other. How do you decide which is a true result and which was a false positive or a false negative? We then persuaded another company to give us free reagents to do tests on that one. So we ended up with deciding which was a true positive by whichever test came out 2 positives, 1 negative. That was a true positive, yeah? And the other one was a false negative. So we had 3 methods, and the third one just to resolve any discrepancy between the first 2. And these are the results. Clearly there were loads of results, so this is just a quick summary. So these are numbers up the other side. The bluey green colour is the conventional methods that we use now, and the pale stool colour is the other one, the Luminex, the molecular system. And along the bottom is the targets that we used. So these are the bacterial targets, the Salmonella, Shigella, Campylobacter, C. diff. Then you've got the viral targets, the norovirus, rotavirus, adenovirus. And then you've got the parasites, which is Cryptosporidium, Giardia, and Amoeba. And then the ones at the other ends of the ones that we're talking about here are the toxins associated with E-Coli. And if you look at, generally speaking, everything you pick up more with the Luminex. So is the Luminex really massively more sensitive than traditional methods? Well, it is a little bit more sensitive, but mainly most of the extra positives were simply because we tested everything for everything. Comprehensive testing means that we pick up a lot more than we did before. So, and you see in our tests, only 21%, during a study, only 21% of those that we tested were actually sent for both virology and bacteriology. So we found viruses here, and we found bacteria there, and we found parasites all over the place. So, once you've decided that what we're doing, all right, sorry, I should also say, come clean as well. By our definition, some true positives were missed by the molecular system, and some true positives were missed by the conventional system. Okay? No test is absolutely spot on every time. You're going to miss stuff. And like I predicted, we got lots of multiple infections. People had more than one infection. So what were the conclusions from this? The conclusions are, at present, we miss many infections simply by the way we test. The selective testing method, which is general, usual method across all labs, all across UK. Selective testing, we miss stuff. So having established that we miss stuff, there is an imperative to change what we're doing so that we don't miss quite so much. So one of the obvious ways of doing it is just to do comprehensive testing using the conventional methods that we're using at the moment. So just expand that and test everything for everything using what we've got. But that would more than double our just consumable costs alone. So you double the cost of all the consumables we use. And we'd also need more staff, which we haven't factored in, more staff to be able to cope with all that. So you've got double your cost of the stuff that you use, the plating out, the molecular stuff, all the microscopy and everything else, plus more staff. Or you can do it by molecular means. And we've had companies offer us at not as cheap as we're doing at the moment, but not as expensive as using traditional methods, but about halfway in between. Okay? So that says, 50% increase in costs, that's still a lot. But then you've got to also factor in the expectation that you will reduce your specimen number by around 30%. Instantly, there's a 20 to 25% reduction for the fact that you only send one specimen rather than two, one to bacteriology, one to virology. So you reduce your numbers by 20 to 25% for that. And there's also a 5 to 10% reduction for repeat specimens that would normally be sent. So you reduce your repeat specimens and you reduce the number of specimens you have to send anyway. So you'd expect that the numbers would just drop by 30% almost overnight. As long as people are aware, hang on, you're going to get a result within 24 hours. We can do that. We will use less skilled, less expensive, and less numerous staff. Clearly we're not going to sack anybody. Nobody gets sacked in the NHS. Not anybody gets sacked in the NHS. But over a period of time, as people leave, they will be replaced with staff who are cheaper, or maybe that post won't be replaced at all. So there will be staff reductions by natural wastage. So we reckon that over a period of time, it would be effectively cost neutral. Clearly that's a little rose-tinted, but it will approach cost neutrality. However, in the short term, it requires investments in the lab. You're not going to make those savings in staff very quickly at all. And with current silo-based funding for this, that and the other, very set, rigid fundings, we're not going to get any investment at this sort of scale into microbiology. So you really need a more holistic view to the whole system. We believe there are substantial savings to be had within the NHS Tayside if we implemented this. However, even NICE did a study of this molecular testing of faeces very recently and published a report. Now, they were all very positive about it, and all their mathematical models said there would be either cost neutral or substantial savings to the health service by the implementation. However, they could not recommend it because there was a lack of published data. The data is simply not out there to support it, because no one's actually switched over to this and analysed it. So basically, we need clinical support if we're ever going to implement something like this. We need hard clinical data. So what we want to do is, first of all, we can't run the two parallel systems next to each other. We can't do the conventional system and the molecular system next to each other. We don't have the manpower, we don't have the space, we don't have the finance to do that. So we can't run them side by side and see how different they are. So what we would suggest is to transfer over to a molecular platform for a set period, a period of 12 months. We would go out and we'd talk to companies and we'd choose a company who could support this, and then we'd change over for a period of 12 months. So we'd be looking for the investment for a 12-month period and assess the impact of that change and assess the costs. And reason for doing it over 12 months is because over that period, while we're assessing how effective it is, we could still revert to our traditional means if it didn't work out. If we didn't realise the savings that we reckon, if we don't have the impact that we expect, we can revert to traditional methods. But my expectation is that we would realise, at least in part, what I'm suggesting, and then we will go out for competitive tender and drive the price of the whole thing down by offering a 5 to 10 year contract. So that's what we want to do. This is what I want you to do, and you and all your colleagues who you're going to go back and talk to about this exciting development. Microbiology may not be that exciting, but this is an exciting development for us. So think about how the change in testing would affect your service and your patients. Think about it. What would you do differently? Think of examples of cases where a quicker diagnosis would make a difference to a patient's journey. How could you change what you do and what you don't do, or how you do it? How many interventions would not happen if you had a guaranteed result back within 24 hours? Possibly even would you consider redesigning a patient journey to take advantage of a slicker microservice? Okay, so you know you're going to get this result back. Are you going to change the patient's journey overall? Are you going to handle your patient slightly differently? If you are, please just tell me about it. That's all we need you to do. Go and discuss it with all your colleagues, think what would happen, and let me know. Okay, and then it may actually come to pass. Thank you for your attention. Have you got any questions?
We have to be very quick because there's only 4 minutes until lunch, until we're all done. Has anyone got any burning questions they'd like to ask? I'll try and make this work. Obviously you mentioned PCR testing for respiratory samples, and look straight at me. It's been incredibly useful to us in respiratory medicine. There's a couple of all the other respiratory people have gone, apart from Simon. MGP. It's been incredibly useful to know when people are having viral infections rather than having bacterial ones, because it's slashed our amount of antibiotics, particularly in cystic fibrosis, which is what I deal with. People come in with what seems to be like a viral illness, and the knee-jerk thing in CF is just to give 2 weeks of antibiotics, and now we can do a swab. You find out that they'll hold off for a day. You find out they've got adenovirus, take 2 paracetamol, see me in a week, and they get better. Mm-hmm. And in terms of microbial stewardship, is incredibly powerful for us in respiratory medicine, because we see quite a lot of infections as well. Has anybody else got any comments they'd like to make? You got your hand up just in time. So just work. There you go.
Hi, at the moment we don't routinely test for C. diff in children because they can harbour it.
Yes.
Would that be influenced? From my point of view, I would actually like to see it more because I look after children with IBD, so we need to especially request it and think about it.
I mean, again, it's one of those things that there is carriage in children, so I understand on the virology.
The one person in Perth can't hear you, so
oh, sorry.
I'm going to stand over there or use the microphone.
Okay, so yes, so C. diff in children is a more difficult area, but that's the sort of thing that, like respiratory testing, you can get the result, but you learn how to deal with that result. And possibly even there's the possibility of suppressing certain results in certain patient categories so you don't confuse. But yes, we could do it very straightforwardly.
Any question?
Yeah, I suppose Pete Fowley, lots of my colleagues have know about my feelings on this. I don't know why we send you any samples.
Okay.
Because for the vast majority of children who come in with gastroenteritis, they get a little bit of rehydration, and within 24 hours they're away home, and then 3 or 4 days later we get a result and we don't do anything about it. So I think, as well as the work that you're doing, it might be worth us thinking a little bit more to reduce your burden on exactly what the criteria are for actually sending you a specimen to look for a virus or a bacterial pathogen. So I think there's other ways of trying to reduce your workload.
I absolutely agree. I mean, we want to diagnose people where it affects their management, not just out of curiosity or protocol.
Oh, Perth has a question. Go on then.
Thanks, Tom.
It's Donald. Hello.
It's following on from Peter. I think it would be very good because, as opposed to a junior trainee just sending off, they're going to have to think, what do I really want from this test, and state it. And I think the number of cases that are sent will be much reduced.
Thank you very much. Yeah, I agree. I think we like to get clinical data. We like people to think about what they do before they send us samples all the time.
Right, the last word.
It's just a comment back about that, Dave. Actually, we had conscientiously decided not to viral swab everybody, so actually probably the opposite to what Tom's doing. We've not swabbed everybody this year, and actually we're aware that there's a significant reduction in number of samples coming into you. So there's probably a little bit about us tying those two conversations together, because it's the same for the ones with diarrhoea.
Yes.
Yeah, and we've gone the other way. We swab a huge number of people because it's so valuable. COPD patients just getting buckets and buckets of antibiotics for what we know. We sort of instinctively knew it was non-infective or viral, and now we know. So there you go, you've got adenovirus. That's fine, it'll settle down. Don't worry about it. Stop the antibiotics, it's great. Okay, fine, so we're done. Thanks very much for that fantastic presentation. Next week, it's still going to be endocrinology, but it won't be hyperphosphatemia. It's going to be something else, which Chris Schofield tells me will be exciting and worth coming to see, but he's not told me what yet. So, thanks very much to the team who gave the presentation. Thanks for coming. See you next week.